Thank you. Thanks, Val. Just before I start, I just noticed that, so I'm actually the third Chief Prevention Officer, and Val so nicely has on my badge, Ron Kelusky, MOL, C3PO. And she's the only one that can do it. I just want to talk a bit about time and money. And the previous speaker, you got to have a vision. And believe me, the idea of creating something in Ontario, because we do have a critical mass when it comes to occupational disease, as well as, over 60% of the population of Toronto are from somewhere else. So the commentary about, building in Toronto to take care of the rest of the world is not a bad concept, and certainly possible in terms of, reaching for the sky. What is the vision that we want in occupational disease? So just a couple of things while the previous speaker was talking, I was looking at some interesting facts. And that when we talk about time, we started this working group, less than 3 years ago. And we're all working towards sort of a rapid solution, and that it will come. But in 1949, it was the first kind of correlation between smoking and lung cancer, where a doctor in the UK took a look at 649 lung cancer patients and found out that only 2 of them didn't smoke. The most immediate thing that happened was he promptly quit smoking. But it's taken 50 to 70 years for that whole cultural shift, where industry wasn't fighting a concept of a correlation, or that people were ignoring the facts. So we went from 80% of the public accepting that smoking was perfectly normal to probably less than 17%. So, time, it will take time to bring everything on board, but the benefit of what we have is we have the benefit of better science. Then I was kind of looking at money, the money side of things. That was really interesting. When I was with the Red Cross, we used to look at global health expenditure, and the global health expenditure was, maybe 5 years ago, was roughly about $10 trillion. And $9 trillion of that was spent by 19 countries. So the other 195 got to share about $950 billion. So when we talk of the burden of occupational disease, especially on those countries that are evolving, we use our healthcare system as really the safety net for a lot of people that are suffering from occupational related illnesses, but those countries don't have the capacity to do that. So it's, what we know and what we can share is probably really important. And when you look at the global economy, which is about $75 trillion, there was a study done actually, and it compared what is the the monetary impact on the economy, the GDP. So the global economy's GDP is about $75 trillion, and Canada's about $1.7 trillion. That they looked at the direct cost of implication of GDP on occupational injury and illness as about 4% of the GDP. So when you look at it globally, it's a fairly big number. It's about $3 trillion. If you look at it from a perspective of sort of the related or indirect and direct costs to the economy, so people that have to leave the workforce because of a psychological or medically related illness to the job, or an occupational disease and a burden on healthcare, the range goes up to almost 15%. That was a study that was done in Finland. So now you're starting to look at $11 trillion globally. That's a big number. That's a huge number. Probably when you take the OECD countries out of that 75 trillion, probably the rest of the 95 countries are sharing that $10 trillion. So it is a huge dollar investment. So dreaming on what is possible is really important. Interesting, the relationship between OCOW and CCOH. um, and is very important. In fact, there was a study that they partnered with that looked at psychosocial issues in pretty much the 15 or 18 primary sectors, working sectors. And it was predominantly on psychosocial issues. And it compared Canada, French Canada, English Canada to Denmark. And there was some pretty striking differences between what is so-called, if they call it a civil society or an investment in people, versus perhaps a less than lack of investment in people. And there were some pretty stark differences to be seen. Our colleague from Manitoba is right. Robust data is really what we need. We have to be able to focus on why things are happening. I had the opportunity in the last 2 weeks, even though there's somewhat of a travel restriction, to speak at the Ontario Building to Trade Conference, 400 health and safety people in Windsor from CUPE. Ottawa, we had a presentation with Kimberly on occupational disease. And probably the fun part was last week to 20 industrial hygiene master's people at University of Toronto. And being able to see there is a passion, and a lot of what I spoke about was on occupational disease. There is a passion both from the learning side to be able to deal with the problem, the working side to be able to address the problem, and from an academic side to be able to solve the problem. You know, ideally, I have a really good prepared speech, but I'm not following it because I'm going to try and get you a bit back on time here. If I always compare this to, my mother got cancer in 2002. And if I compare how cancers are treated then to nowadays, the difference is phenomenal and mind-boggling. I mean, physicians and systems are on the clock. As soon as someone is diagnosed with cancer, they are measured. They have in a matter of days. You must have treatment prescribed and in place in a matter of days. And if you're not, you're held to account for it as a system. And back then, you had a lump, you went to your family doctor, he got you an appointment with a specialist who got you an appointment with a surgeon who gave you an appointment for surgery, then your pathology was sent away, and some weeks later it came back to the surgeon for the interpretation, then it went to the family doctor, you scheduled your appointment, and it was weeks. But today, if you have a family history of colorectal cancer, as an example, you're put on surveillance. And you have your first colonoscopy and they find something, they make you come back every 3 years or every 5 years, they put you in a program. Wouldn't it be nice that when we can draw the correlation between working with substances or working in environments where the family physician recognizes it and can put you on a surveillance program. Do you know, in Ontario, there's 443 fire departments, of which 28 are full-time. And there is only one fire department that actually has an occupational disease surveillance program that looks at the medical aspect of an annual physical checkup and exposure tracking and so on. One of them, just one out of 28. Yet we know that, from a WSIB perspective, the presumptions for occupational cancers in firefighters are fairly substantive, and you would think we would jump on board. So anyway, being able to work towards that ability to get surveillance and to have a system that people that handle chemicals in facilities that are registered with the Ministry of Environment, are registered with the Ministry of Labor, and those same business registration numbers are on file with WSIB. So it makes it easier to draw those correlations as we go along. And that, people look at it and say, and I'm going to You can steal this if you want. There's three things. We have to have a system. We have to have science. And we have to have surveillance. And if we put all those three together, we'll probably have dealt fairly effectively with occupational disease. I read an article the other day from Australia, and it was on silica, that said that, how many people have had their kitchens remodeled in the last 4 or 5 years? Or bought a house that's got artificial stone countertops? That they are saying that those people that are handling and cutting and installing artificial stone countertops, that the frequency of silicosis or silica-related respiratory problems has just gone through the roof. Like, we're talking people in their early 40s. So not a manifestation, when they're in their late 50s or early 60s, we're talking early 40s. And that study indicated that they're even more fearful that this will even surpass the significance of mesothelioma. So we know we got to get that education out there. God knows we've got the knowledge. It's it's the problem, and it's just plagues. This is my 8-month view, that we have the knowledge. It's the knowledge transfer that's the challenge that we have. That people, we're talking in this room to 100 or more people that believe, drank the Kool-Aid, got the tattoos, sincerely believe in what we're doing. And when we talk to the people, we have to talk to the rest of the world in a language that they understand, a language that they will absorb, and in a language that will allow them to act accordingly. And that goes for employers and workers. Because last year in Ontario, we had 80 traumatic fatalities and 127 occupational disease fatalities. And that's unacceptable. We want to look at the science, and I'll just leave you with something that we found. And this is the importance. I believe very strongly in the public health model, and a lot of people are aware of that because I sound like a broken record. But the whole concept of the epidemiology of disease, of investigation, of understanding the question why. So we look back 10 years into falls, and we have probably, I think we're up to 18 or 19 traumatic fatalities as a result of falls from heights this year so far. And they're all over the map. There's not enough there to draw a pattern. There's not enough there to be able to figure out why things happen. And, when you have 80 traumatic fatalities a year, it's pretty difficult it's not a big sample size. But when you go back 10 years and then you start going back into as much of the investigative data that we have as possible, that's inspector notes, that's not just relying on WSIB information, but actually understanding what was going on at the time that it happened. And yes, there's the normal stuff that it's, a guy wasn't wearing his fall arrest, or it was improper. Those are a no-brainer. Those are the ones we already know about but can't figure out why. But as we got into it and we started to look at time, 15% of those fatalities occurred in the first month. They were general laborers. So when we start looking at those statistics and start matching that with time of day, circumstance, level of orientation, the fact most of them were general laborers, but also when we started to look at age, they were new employees, but they weren't, the 18-year-old kid fresh out of high school. They were people that are, for reasons of economics, were forced to get a job that they weren't skilled at. They were new Canadians as well as youth. So, well, it's not a 100% solution. There's not really many 15% solutions left in the health and safety world where you can actually take a chunk out of it. What even worse was that the majority of the numbers died within the first 4 years of the job. So we got to figure out why these things are happening. I know that we're just getting started, and we are broadening our relationships. I like the idea of trying to find as many friends that are interested in this topic and sharing information. As was stated, Canada, Ontario is good compared to the rest of Canada, but we're not great when we compare ourselves to the rest of the world. We're like the lower third when it comes to OECD countries, like 22nd out of 32. So, you know, we got a lot of room to grow. But collaborating and sharing is very important. The leadership that OCAL has shown on this file with the support of others has been nothing short of amazing. And, you know, we're going to build our intelligence. We're going to build, continue to build our argument for maintaining momentum on this file. Certainly when we look at our strategy, and we will be moving forward with the next 5-year strategy, occupational disease and both physical and psychological wellness of workers will be an important aspect of it, as will be evidence-based, outcome-based, focusing on the highest hazards that are hurting and killing Ontario workers will be a focus, and using the science and public health approaches to be able to figure out what's going on will certainly be my priority. Really, there is a compelling argument for the economics of health and safety, especially when it comes to occupational disease. If we were to look at this government, there is a compelling argument as well to shift the burden of responsibility from the healthcare system onto the other system, because right now a lot of people are, the safety net is in healthcare. I always like to say prevention is first aid for the uninjured. And always remember, it's cheaper to keep Humpty on the wall than to try and put him back together again. So stick around for the afternoon, because the focus groups are really what's important to be able to help continue this priority. And I thank to all the collaborators, and I thank you, Michael, and Val, and Kimberly, and all the staff at OCAL for really, you know, putting your shoulder into this one. It's really worth it. All right, have a great. Always get stuck between me and lunch, so, or usually me and alcohol at the end of the day. Anyway,
No alcohol.
have a great afternoon. Thank you.